Arrhythmias are disorders of cardiac rhythm, and conduction, and it can be classified as bradyarrhythmias. That's when the heart rate is less than 60 beats per minute. And tachyarrhythmias, when the heart rate is greater than 100 beats per minute. Bradyarrhythmias include sinus bradycardia, sinus pulses, and atrioventricular blocks. The tachyarrhythmias can further be classified into supraventricular and ventricular arrhythmias based on their site of origin. And tachyarrhythmias include atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, ventricular tachycardia, and ventricular fibrillation. So prior to drug treatment of a suspected cardiac arrhythmia, a 12-lead ECG must be done to confirm the rhythm abnormality. It is dangerous to use an anti-arrhythmic drug without doing an ECG. So refer symptomatic patients to hospitals immediately. And the choice of drug treatment depends on the type of arrhythmia and the severity of the symptoms. So the causes are rheumatic heart disease, other valvular heart diseases, hypertensive heart disease, ischemic heart disease, thyrotoxicosis, hypothyroidism, cardiac myopathies, and cardiomyopathies, complete heart block, electrolyte abnormalities, particularly hypokalemia, pericardial disease, drugs, smoking, alcohol, caffeine, tea, pulmonary embolism, post-cardiac surgery, and idiopathic causes. The symptoms are palpitations, dizziness, chest discomfort or pain, fatigue, difficulty in breathing, sudden collapse, sudden death. The signs are pulse. The pulse rate may be fast, slow, or even normal. The rhythm could be regularly irregular, or irregularly irregular. For the regular, it indicates sinus bradycardia or sinus tachycardia, complete heart block, supraventricular tachycardia, or ventricular tachycardia. Regularly irregular suggests supraventricular or ventricular ectopic beats, and irregularly irregular depicts atrial fibrillation, atrial flutter with variable atrioventricular block, multiple supraventricular or ventricular ectopic beats. Pulse deficits could be present. That's apical rates faster than the radial pulse rates, and this is seen in fast atrial fibrillation or flutter. Also, hypotension, or blood pressure may be unrecordable. Also, signs of heart failure may be present. Investigations are 12-lead ECG, serum electrolytes, including magnesium, calcium, thyroid function test, chest X-ray, ambulatory ECG as Holter, and also echocardiography. The main treatment objectives are to control ventricular rates, to restore sinus rhythm, to relieve symptoms, to improve functional capacity and quality of life, to prevent or treat associated complications, to treat the underlying condition, for example, thyrotoxicosis, to prevent stroke or systemic thromboembolism, and also to reduce morbidity and mortality. Non-pharmacological treatments are reassuring the patient, avoid excess intake of alcohol, cafe or tea, and stop smoking if these are possible precipitating factors. Also, massage of the carotid sinus on one side for a few seconds. This may terminate an attack of paroxysmal supraventricular tachycardia. And electrical cardioversion. Pharmacological treatments are first atrial fibrillation or atrial flutter for rate control. The first line treatment, you give atenolol oral, adults 50 to 100 milligrams daily, in children 12 to 18 years. We give 25 to 50 milligrams daily, and 1 month to 12 years, give 12.5 to 50 milligrams daily. Neonates, you refer to a pediatrician. You could also give bisoprolol oral in adults 2.5 to 10 milligrams daily, and in children safety is not established, so it's not really recommended. And you can also give metoprolol tartrate oral in adults 50 to 100 milligrams 8 or 12 hourly daily with a maximum dosage of 300 milligrams daily, and in children 12 to 18 years 50 milligrams 8 or 12 hourly daily with a maximum dosage of 300 milligrams daily. And children less than 12 years, you refer to a pediatrician. Avoid if beta blockers are contraindicated, for example in bronchial asthma and in hypotension. You could also give verapamil oral in adults 40 to 120 milligrams 6 to 8 hourly. The maximum dosage of 480 milligrams daily. For children, refer to a pediatrician. Avoid use in patients already on beta blockers. Second line treatment, you give digoxin oral in adults 125 to 250 micrograms daily. In children, refer to a pediatrician. For fast atrial fibrillation or atrial flutter for rhythm control, it is required to restore sinus rhythm. So refer to a cardiologist, physician specialist, or pediatrician as appropriate. For paroxysmal supraventricular tachycardia, first line treatment, you give atenolol oral in adults 50 to 100 milligrams daily, and in children 12 to 18 years, give 25 to 50 milligrams daily, and 1 month to 12 years, give 12.5 to 50 milligrams daily. In neonates, you refer to a pediatrician, but also give bisoprolol oral as for the paroxysmal supraventricular tachycardia. In adults, 2.5 to 10 milligrams daily. In children, is not required, but safety is not established. Or you could give metoprolol tartrate oral in adults 50 to 100 milligrams 8 or 12 hourly daily with a maximum dosage of 300 milligrams daily. And in children 12 to 18 years, you give 50 milligrams 8 or 12 hourly daily with a maximum dosage of 300 milligrams daily. Less than 12 years, you refer to a pediatrician. Avoid if beta blockers are contraindicated, for example in bronchial asthma, hypotension, or hypertension. But you could also give verapamil oral in adults 40 to 120 milligrams 6 to 8 hourly with a maximum dosage of 480 milligrams daily. For children, refer to a pediatrician. Avoid using patients already on beta blockers. The second line treatment, you give digoxin oral. That's for paroxysmal supraventricular tachycardia in adults 125 to 250 micrograms daily. In children, refer to a pediatrician. Prevention of stroke or systemic thromboembolism in atrial fibrillation of flutter. The patient should be given long-term anticoagulation. Referral criteria: refer patients to a cardiologist, physician specialist, or pediatrician for further evaluation and management after the initial treatment. All symptomatic patients, as well as those who cannot give an who cannot have an ECG done or interpreted, or who present with heart failure, should be referred immediately. So let's look at the flow chart. The patients presenting with atrial fibrillation, we assess thromboembolism risk, also manage atrial fibrillation or detect and treat precipitating causes. With the management of atrial fibrillation, we do with the rate control and rhythm control.